Hello, everybody.
Hello.
Hello, Professor.
Hello, Stephen.
Okay, so hello, everybody, and welcome to today's meeting. My name is Stephen. I'm a general practitioner dentist and the education manager of Austin, Middle East. Today, I will be the host of our meeting. It's my pleasure to have you here tonight, live on Zoom. We are Austin, Middle East. We are supplying Austin products in the Middle East area and Africa. And we focus on the scientific community, the OIC, worldwide. So actually, Austin established South Korea's first implant training center in 2001. And we provided dentists in South Korea and other countries with training. And we trained more than 110,000 dentists across the globe. And we are expecting by 2026, we will train 160,000 dentists around the globe. So this is briefly our scientific community and our vision about education in Austin, Middle East. And today our webinar, it's our first series of live webinars that will be held every month about digital dentistry solutions. And with honor, this topic will be covered by Professor Marco Tallarico. Professor Marco, DDS, Master of Science in Oral Surgery, Director and Research Project Manager of Austin OIC Italy, certified in implant-based therapy, European Association of Osseointegration in 2013, Assistant Professor at the Department of Medicine, Surgery and Pharmacy, University of Sassari, Italy. Expert in digital solution, more than 100 publications on peer-reviewed journals. Private practice limited to dental implants and prosthodontics in Rome, Italy. So before we start, please keep your microphone off and the video also. And if you have any question during the webinar, you can write down in the chat section. And by the end, the Professor Marco, he will answer as much as he can. Hopefully he can answer all. And stay focused and please turn off all distractions around you. So it's our honor to have you, Professor Marco, tonight. So shall you start the lecture?
Unmute. Okay, it's my real pleasure and honor. I'm sharing my screen. I think it's okay, Stephen. Okay, I see. Okay, perfect.
Yes, yes.
So thanks for the kind introduction. I'm really proud to be the speaker of this webinar today, the first of a series of webinars. I'm really proud because I really enjoy to be Austin users. I am a researcher, so I really enjoy to be part of a scientific community. For me and for a lot of users is very, very, very important. And I really thanks all the Austin and Austin Middle East for these opportunities. Today, I want to skip myself. I just want to introduce my city. I live in Rome. These are short video about my city, Rome, and about Dubai. It's my pleasure that I will be in Dubai next year in February. This is my clinic. As Stephen told before, I live and work in Rome, and my passion is dentistry, of course, but also digital technologies. That is the topic of this webinar. In my clinic, we have a lot of training, and in this video, you can see also training with digital technologies. One of the most passionate topic for me is guided surgery, and we will speak also about this. This picture is a live surgery that I performed several years ago from Austin. So moving to the agenda, because I have a lot of materials to share with you. Today, we will speak about scan. I divided this webinar in scan, plan, execution, and finalization. Scan means diagnosis. I really believe that the diagnosis is the key of the success of all of the treatment in medicine, in dentistry. And a poor diagnosis means a poor treatment plan, and poor diagnosis and poor treatment plan means risk of complication and failure. Today, the topic is iOS, intraoral scanner, CBCT, and WhatsApp. People that already use computer-guided surgery knows that we need 3 data to plan our cases of guided surgery. The anatomy of the patient using a CBCT scan, the radiographic anatomy, the bone quality and quantity, the anatomy of the mouth, soft tissues and hard tissues, the teeth, and we can collect with intraoral scanner. And we need a WhatsApp because we need a prosthetic setup in order to plan our implant in the best prosthetically driven position. Particularly today, I want to introduce a Smile Creator to make a digital WhatsApp for our patients. However, today I will show you some cases on natural teeth and some cases on implant, because I want to introduce these 3 concepts. Starting from the CBCT scan means DICOM files that we need to import in our software to make the diagnosis looking at the radiographic anatomy of the patients. So the CBCT scan was introduced in the late 1990s in the dental and maxillofacial files. CBCT scan allow us to see the 3D visualization of the anatomical structure on the bone and the relationship with the important anatomical structure. Different from the CT scan, the radiation dose is lower for the patients. In 2012, CBCT scan was recommended by the American Academy of Oral and Maxillofacial Radiology as the best, the gold standard for our patients. So the application of the CBCT scan are for assess the anatomy for implant surgery, but we have a lot of application because CBCT scan allow to see the bone height, width, bone quality, bone quantity, also to follow up the patients. We can see the alveolar ridge, anatomical structure, everything, including dental alveolar structure, the teeth, and TMJ. So we can use a CBCT scan not only in implant surgery, but also in orthodontics, in endodontics, in a lot of files in dentistry. Why we use CBCT scan? The difference between a CT scan and CBCT scan are about the method used to acquire the image. CBCT scan use a cone-shaped beam, as the name suggested. The traditional CT scan use a fan-shaped beam or spiral scan to collect the medical images. In brief, CBCT scan shows a superior resolution but lower quality of the image, but also less dose for the patients. This is the reason why we use CBCT scan in dental field, because we need high resolution. However, the limitation of the CBCT scan are relative low contrast with the soft tissues. To improve the visualization of the soft tissues in the guided surgery, we combine the CBCT scan with anatomy of the patient so we can see the contour of the soft tissues. If we don't plan a guided surgery, we can improve the soft tissue contrast using lip retractor, for example, cotton roll, in order to separate the gingiva from the vestibulus. Another limitation is that we cannot use the gray levels in the CBCT scan to measure perfectly the bone using Hansfield unit, even if modern CBCT scan using multifocusing sensor allow to have a good image, even the quality of the bone. Here you can see the main factor for the CBCT scan, that is the voxel. In the CBCT scan, as I told you before, we have high resolution. This means very small voxel with a resolution of 0.075, for example, up to 0.1, 0.2. CT scan have a resolution that was a little bit higher, 0.4, 0.5. However, as you can see in your left, the quality of the CBCT scan is lower than the CT scan. Another limitation, but also for bidimensional radiograph, is that we have an underestimation of the bone of about 1 millimeter in 24% of the cases. For example, this is the reason why we estimate a residual bone 8 in the maxilla for crestal approach, and very often we have a little bit more bone than we expected. However, the underestimation protects us. Other benefit for the CBCT scan is the possibility to segment 3D model, to print, but also we use a segmentation in the double scan protocol for the guided surgery. As I told you before, high resolution of the bone and low radiation dose for the patients. We can also reduce the exposure for the patient. It is most important, not only the characteristic of the machine, but also the protocol that we use. So it's most important to control and to set the protocol when the patient underwent the CBCT scan for several reasons. For example, guided surgery. Exposure time is not possible to change, angular degree of the gantry, but we can control the milliampere and the size of the field of view. That is very, very, very important. So the most important requirement, as I told you before, is the spatial resolution, but we need a balance with the milliampere, with the power of the machine, and the low radiation zone. So, as I told you before, it's very important, the protocol. We have different machine. If you need to buy a machine, it's most important to have a minimum FOV of at least 8-9 centimeters, because the recommended FOV for the guided surgery, for example, is 6/8 in the mandible, and I suggest 8/8 in the maxilla. We can also have a 5/5, but just endodontic. We can have also improved the FOV, but using the stitching. The stitching, if possible, is not recommended because there is the possibility to make some mistakes. But in general diagnosis, we can accept. In guided surgery, we cannot accept. So very briefly, I suggest to make a screenshot of this slide. In order to plan our cases of guided surgery, we need to control the field of view of our CBCT scan, large enough to take an image of the entire bone, particularly if we use, for example, an extraoral marker. We will speak about this in the next webinars. But as I told you before, minimum FOV of 8/8 and 8/6 in the mandible. In case of partial restoration, at least 5 teeth in 2 quadrants to have an accurate merging of the impression and CBCT scan. Resolution lower than 0.5, but as I told you before, CBCT scan a very high resolution, so this is not a problem. The higher quality as possible. The scanner must be calibrated very often. I calibrated my scan 2 times for here. It's most important that the data must be exported in single DICOM file. Then if we use a radiographic guide, the radiographic guide must to fit very perfectly in the patient mount and must to be stabilized in occlusion. And last but not the least, in case of partial edentulous patient need to wear the CBCT scan with the mount opened in order as you can see in this picture, to visualize the occlusal surface of the teeth that are used for matching. Here we can see CBCT scan. The FOV is 8x8. In case of maxilla, I suggest to improve this FOV because we need to see the maxillary sinus cavity. In this part of the software, we can set the density of the 3D. Here we can plan the CPR in order to reconstruct in the axial view the panoramic view that you can see in the lower of the screen. This is an example for the maxilla, and this is an example of the mandible. We can sign the nerve as an important area, in this case just one side, and we can plan and we can see all the CBCT scan in the 3 planes, coronal, axial, and sagittal, and of course the 3D model. Sagittal plane divided the skin in right and left, the coronal plane divided in front and back, and the axial or transversal plane divided in top and bottom, the skull of the patients. However, when we plan an implant, we use the 3D model and we use the cross-sectional view, that is a sagittal view of the CPR that we signed before. These are some examples. If we place an implant, we can move the cross in order to see the implant at 360 degrees. So, moving to the second topic, after introducing the CBCT scan, I want to introduce the IOS intraoral scan in order to acquire digital impression of the patient mouth. So we have STL file. Very brief intraoral scan operation begins with the emission of a light. Today, the most modern scanner used the LED, in the past laser of structural light. This light is reflected in a mirror and is captured from some cameras. For example, the Medit uses 2 4K cameras. Of course, we need a software that is able to recognize the shape of the light and calculate in 3D coordinates x, y, and zeta the clouds of the points, resulting in a mesh image. So finally, the image is STL file, but is a mesh image that is a lot of clouds that constitute the object that we scanned. Different from the CBCT scan, we have a progressive stitching, so it's very, very important to have overlapping area, but that these areas are completely accurate. We will see in a few minutes the suggested technique. With the iOS scan, we can directly have digital file. In my practice, I use a lot the digital scan. I have 2 Medit in my clinics. Today, I use intraoral scanner for the diagnosis in 100% of my cases. I started to have impression in the first visit. So the patient maybe called me a few days later. I accepted the program, doctor. So I have already the impression to set guided surgery, temporary restoration, everything. In case of fixed temporary restoration, again, 100% of the cases. In case of definitive restoration, speaking about a single teethed implant, maybe 90%. Still, a small part of my practice is analog. Looking at the small bridges, 2-3 units, teeth and implant, the same 90%. In the rest, complex cases, bridge of 4-5 units and full arch. Personally, I use a digital scanner in 70-80% of my cases, but sometimes for research reasons. Because the accuracy is very good, but the precision, the reliability is still not 100%. But I noted a very improvement week by week, month by month. So I expected that in the next year, 2 years, we can safely recorded 100% of also complex cases on natural teeth and full arch restoration. Today, removable prosthesis is still completely analog. Moreover, patients have a lot of confidence, a lot of comfort using digital impression. So also from a marketing point of view, intraoral scanners are very convenient. As I told you before, the accuracy is very, 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 very important. So introducing the intraoral scanner, I want to speak about the scan strategies. I want to introduce this manuscript. The author tested 10 scan strategies. Don't worry, I just will speak about one strategy, but the authors divided in single scan, 2 scans, and 3 scans. In case of multiple scans, the scan will be matched using the stitching. As I told you before, the stitching is a superimposition of 2 images in overlapping images in order to create only a single object. However, as I told you before, it's most important that the overlapped images are very, very accurate with a lot of clouds, a lot of points in order to have an accurate matching of the single scans. And this is the conclusion that I already stated to you. Here, I want to go a little bit quick. This is a video. The first step when we scan is landing. We need to land in an area that is very big and clear. So usually the occlusal surface of the molar. As you can see, we move on the canine, then we rotate a little bit on the palatal area and scan the palatal area of the molar. When we scan, we can a little bit rotate with a very, very, very short zigzag movements in order to change the orientation and the view of the scanner, so it can collect more data and the image will be more accurate. As I told you in the video, after that, we move on the first molar and we move buccally in order to record the buccal surfaces of the teeth. At the level of the canine, we need to improve the movement of the zigzag. Look at the video. Why the zigzag movement must be more wider? Because the incisal surface of the anterior teeth is very small compared with the occlusal surface of the molar. So we need to make a rotation, zigzag, in order to collect more data. At the middle, we have 2 shunts. In the maxilla, it's very easy to rotate the scanner without power off. Or, as you can see in the video, to power off the scanner, power on again, and take the second scan. But as I told you before, the single scan is more accurate. The 2 scans matched between them are the same accurate. The 3 scans are not suggested. So the stitching maximum between 2 different scans. However, as I told you before, in the maxilla, I suggest to rotate the scanner without power off because we have all the palatal area of the central incisor that is suitable for the rotation. Then we move on the occlusal surface of the molar, go back, palatal area, go back to the canine, move in the buccal area, and take the vestibular surfaces of the teeth. During these steps, always a little bit rotation, not like in the incisor, zig and zag, but just a little bit movement in order to change the orientation of the scanner and to have a more readability images. I go very quickly because in this case, you see a preparation. And now I'm just taking more area because there are some holes. This is normal in the interproximal area. Avoiding overlapping. So take off the scanner, move to the holes on, and just to take the new area. Now I'm cutting the abutment because I want to take with high resolution. For example, I use the double cut techniques. In case of natural teeth, I remove the cords, put the scanner in high resolution, and take just the cutted area. So I start to the surface of the molar because it was already acquired. You can see the color is different because the scanner is in high resolution. This means that we have more defined mesh with more points in my mesh. Look here, I move the scan vertically because I need to move the scanner in order to collect, to record the interproximal area that are very, very important for the contact point of our crowns. Move the scan, put the scan vertically, and then rotate on the right and on the left in order to record the interproximal area, both in the palatal and buccal aspect. I go quickly. In the mandible, I will quickly because the strategy technique is the same: occlusal surface of the molar, coming back on the canine, lingual, and buccal area. Then zigzag in the incisal area. In the mandible, I suggest to stop the scanner to make you comfortable and to start again to collect the second area. When you collect the second area, you can start on the previously acquired area, or you can start on the molar area. And then the software will apply the stitching tools. However, in the mandible, sometimes it's not easy. So another strategy is in the mandible, as I told you before, the same strategy for the maxilla. In the mandible, just to take off the scanner, move, and then start again, using, if you want, also the stitching. But we have another strategy that is to collect immediately the lingual area, starting from one molar to another molar, in order to collect immediately the lingual area, and then from the lingual to the occlusal to the buccal area, rotation movements. So rotate for the lingual to the buccal, and then again from the lingual to the buccal, and step by step we move on the middle. This is a little bit longer technique, but in some patients is very, very, very complicated to take the impression in the mandible. In the maxilla, I take impression just with the Optragate lip retractor, while in the mandible, I need my assistant supported me. This is the, I close some holes, and then the occlusion. Occlusion, you need to use the spray, the air, because the teeth must be very, very, very dried. I remove any kind of retractor because the patient could be a little bit suggest conditionated, and then take the occlusion. If the occlusion is taken very quickly, well, this means that the impressions are good. If we have some problems, you need to check if your previous impressions are good, or if the patient close well the mouth. After the strategies, very quickly, smart stitching is the tools that I stated before in order to make just one impression starting from 2 or more segments. However, as I told you before, please just stitching of maximum 2 different scans. After I'm sorry, I just saw that I moved. Steven, can you tell me when I was mute? Because I didn't touch nothing, but okay. So I start maybe from here. I don't know when my microphone was mute. Smart stitching, but my recommendation is maximum 2 different scans. Filtering are no filter, teeth and gingiva, only teeth. Here you can see different image. Usually I use teeth and gingiva. However, in the mandible, if you have a very, very complicated mandible, you can use just the teeth, particularly if the mandible is just... Steven, I don't know why my microphone was mute. I didn't touch nothing. Please, can you check?
Yes, everything is okay. We can hear
yes,
well.
I didn't touch nothing.
Yeah.
Okay. And no filter if you scan, for example, removable prosthesis, for example, metal, for example, 3D marker in guided surgery. If you don't scan teeth and gingiva, you can remove the filter. This is a very nice function because it's map of reliability. Here you can see red, green, more green. When you scan an image, as I told you before, we have a lot of clouds that are used to realize the mesh. If you have a lot of points, the image will become more green. Red is still not accurate. A little bit green start to be accurate. When is very, very green, it is very, very accurate. So I use this function in all of my impression because I want a very, very nice and accurate impression. How you can scan in order to have a real, a very accurate impression? As I told you before, moving a little bit the scan rotation a little bit right and left when you move on the teeth in order to change the orientation of the scanner. Because if you put the scanner in the same position, you acquire the same points. You need to move a little bit in order to allow the scanner to collect the same object in different perspectives. Other tools to check the undercuts, you can remove and take again the impression to check the distance from the antagonist. If you have no space, you can cut the abutment and scan again after reduction, for example. And also with the implant, you can immediately recognize the scan abutment, or in case of natural teeth, you can immediately define the finish line. And then you have a lot of apps. Unfortunately, we have no time to explain all the app. So just 1 minute to introduce the Smile Creator, and then I want to share with you some cases using CBCT scan, intraoral scanner, and Smile Creator. Smile Creator is just an aesthetic workshop, but also functional workshop. So the concept is to create a digital pre-visualization of the teeth to be rehabilitated from an aesthetic and functional point of view, and then to generate an STL file of this simulation. Because, as I told you before, we need DICOM file, CBCT scan, we need intraoral scanner, STL file, and we need a workshop to prosthetically drive our implants. For example, these patients, we need to extract some upper teeth, but we need to make a workshop. The patient is also a little bit older, but she feels very younger. So she wants very wide teeth and very wide teeth. This is the situation from a periodontal point of view. So we need to extract the molar in the upper and lower jaw, and we need to cover the anterior teeth. What is Smile Creator? As I told you before, is a pre-visualization, and we need intraoral scan of the patient mouth, and we need two pictures, extraoral picture, one with the retractor and one with a smile without retractor. It's very, very important that these two pictures are very similar picture, taking the same moment without any movement of the patient head, because then we need to merge and to make a superimposition of these two pictures. Look here, the patient have a very black area between the teeth and the cheek, and she wants to fill this space. This is a superimposition of the impression on the picture with the retraction and then without the retraction. Then we set the proportion of the teeth to be rehabilitated and create our virtual walks-up. I will show you later in detail. After we create a virtual walks-up, we can create a physical model and to print temporary restoration, like in this example, and then using the temporary restoration to create the final restoration, as you can see. I will explain in detail the process of the Smile Creator, starting with some cases. The first three cases are natural teeth, and then 3 cases on implants. The first patient is Ludovica. Ludovica was very young when I started the treatment, 13, 14 years old, but she started with orthodontic treatment, and then she changed the smile with some veneer. But how we can use a Smile Creator? Communication is very, very important. Ludovica is a young model. Even if it's very young, is a very, very particular age, is a teenager. So she came in my clinic, 14 years old, with a diastema in the anterior teeth, and she wants to close, but she has some problem from an orthodontic point of view. So I spoke with her, but I needed something to convince her to start before an orthodontic treatment and then some cosmetic treatments. So I focus on Ludovica on function and aesthetic. Of course, the patient just wants the aesthetics, but I need to focalize on the function. So I start my protocol, Smile Creator. As I told you before, intraoral scans and 2 pictures, very easy. Picture with the retractor and picture with a smile. Then we need a software. The first step is to make a superimposition of the intraoral scanner in the bidimensional picture using just 2 reference points at the level of the canine. Then we can move the impression in order to find the best alignment as possible. Teeth detection, the software needs to recognize the teeth. In the new version, this function is automatically because we can use the intelligence artificial in order to make an automatic teeth detection. And then we need to plan our treatment. In this case, after segmentation of the teeth, we proposed 2 treatments to Ludovica. The first is just with orthodontic treatment. Orthodontic treatment was good, aligned but not beautiful teeth, because the patient wants to change a little bit the shape, because it's very, very square teeth, longer and short and narrow. So I agree that are not so beautiful. With the veneers, the problem is that veneers without orthodontic treatment, we have 2 problems. The first is that the teeth is very big because we need to close the diastema. Another problem is that in order to have the veneer perfectly in the midline of the patients, we need to make a very big reduction of the natural teeth because, as you can see in the picture on the right, the middle is not centered. So she's very young, so it's not possible to prepare the teeth. And after this picture, I convince her to start an orthodontic treatment. Just very quickly, the orthodontic treatment with some aligners. After orthodontic treatment, we put the midline on the middle and we close the space. So we can move to a mock-up. Mock-up is just an addictive mock-up, showing to her to change the form, but most important is no prep veneers, only on the enamel, without any kind of preparation. She's very young. I want to cement, I want to bond my veneer on the enamel and also to give a natural aspect. And this is the final appearance of the patients with some emotional picture. But intraoral scanner and Smile Creator allow me to communicate with the patient and to suggest her to accept orthodontic treatment before and veneers later. And this is the follow-up after orthodontic treatment and veneers. So very quickly, a second case, innovation. I want to share with you a new way to take impression using a vertical preparation. As you know, biological oriented preparation technique, also named BOPT, is introduced by the Italian doctor, Dr. Loi, and is used in the vertical preparation using a preparation of the teeth, gengivage, and seal the soft tissue with a temporary restoration, allow the blood clot to stabilize, and then to move down using the temporary restoration. As you can see here, we have a blue shape of the teeth, and we need to move the soft tissue down. Unfortunately, we have not time to explain all the procedure, but look here after 2 to 3 weeks, and again, after other weeks, we have a good shape of our teeth. Now we move to the impression. In this case, you see 2 impressions, conventional impression with the cords, but also innovative impression without cords. Why? On the right, you can see 2 different areas. Here is the level of the tissues, and the gray is the level of the tissue after displacement by the cord. On the left, you can see on the blue area and here and the red here that with the cord, we make a displacement of the tissues that we used for the horizontal preparation to make the dental lab to view the finish line. But in the vertical preparation, we have not finish line. So what is the innovation? No retraction cord, because we don't want to make any kind of displacement of the tissues. So the step is to collect the impression of the abutment without any kind of the cord, impression of the temporary in the patient mount, and the impression on the temporary out of the patient mount. The software automatically matched, or we can match manually in order to have the temporary restoration in the impression. Why? Because we took an impression without any kind of cord, but the tissue can collapse. So we need something to reopen the tissues and to perfectly communicate with the dental lab the finish line. I'm sorry. So here you can see this is the cervical part of the temporary. In the cervical part of the temporary, we have finish line and emergence profile. So with a subtraction tools, the name is Boolean, we can reopen the sulcum in order to share with the dental technician the finish line, that is the end of the temporary, and the soft tissues emergence profile. And here you can see the final restoration, digital lithium disilicate, and with ceramic on the cervical area. But also look at the soft tissues that are very, very good. So intraoral scanner, in order to make some innovation impression in the BOPT technique without retraction cord. Here, I want to show you another case, vertical preparation using intraoral scanner and again, Smile Creator. Marco is a best friend of mine. He has some periodontal problems, as you can see, and a very big diastema and deep bite. So a lot of problem in the anterior area that make this treatment very complex. Periodontal problems, diastema, aesthetic problems, and deep bite, functional problems. Here you can see the periodontal probing depth and the intraoral picture. Once again, two pictures, one with the retractor and one just with a small smile, intraoral scanner. Once again, this is the first workshop, but we want to make a Smile Creator. So 2 points, 2 points, and we make a superimposition. The superimposition, we move the impression in order to have the best alignment as possible. And then we make a superimposition of the two pictures with or without the retraction cord. After that, we have the 3D impression superimposed on the picture of the patients, and we started with the workshop. The first step is to define the proportion, then to define the shape of the teeth with the library. And finally, we can control on the bidimensional view and in the three-dimensional view. The best innovation is that we don't have only a picture to show with the patient. We have a digital model. We can print a physical model and we can print a temporary restoration. Another benefit of the Smile Creator is not only from a marketing point of view, because the patient can see on the screen before starting the treatment. Another benefit is that we can provide more than one project to the patient. For example, with the diastema, without the diastema. You will see that my patient, after the first temporary restoration, he decided to close the diastema. Initially, he wanted to maintain. So we can propose to the patient more than one project. As I told you before, from the model that you can see on the right, we can print a prototype model and we can print a temporary restoration that is the same that we test virtually and show it to the patients. The first preparation, initial preparation, and put the temporary. After the periodontal treatment, we have a modification of the soft tissues, but we started with some modification, BOPT technique, biological oriented preparation technique, create a very stable, strong blood clot, and starting to moving, refine the teeth using magnification in order to create more space for the papilla here. Secondary temporary with the diastema closed and waiting. I really enjoyed the concept of slow dentistry philosophy because very often we need to wait for the biology. Here the diastema is just a little bit reduced, but after 9 months we see papilla grow because here we have pushed with the temporary, here we have created space after the first blood clot stabilization and step by step to move down the papilla. Look here, the papilla grow here and the tissue grow a lot. These are my final preparation. Look at the microscope, the tissues is very, very nice. And finally, the digital impression. Digital impression, I already introduced it. It's very, very, very useful in this case because I can send directly to my dental technicians superimposition of the preparation and the temporary. So it's very easy for him, for her, for the dental lab to copy the temporary shape, but also to copy the emergence profile and the finish line that I spend a lot of time to modify the tissues. Here you can see a preview of my preparation with the cord because I finished this case 2-3 years ago. All the spaces the sulcum. And also, as I told you before, this case was complex from an aesthetic point of view, periodontal point of view, but also for a functional point of view. If you remember, the patient started with a very deep bite. So I needed to create a new aesthetics to reduce the deep bite, but maintaining incisal function, anterior guidance. So with the software, we can control the mandibular movements and to apply in my digital files. Personal mandibular movements are very important in the digital and is very fantastic because in the past, to collect individual movements, my colleagues spend a lot of times. Now, with the digital technologies, it's very easy and quickly. Here, the function. Look here, the movements. That even if we reduce a lot the deep bite, we maintain the function. The diastema was closed just a little bit open, and these are the definitive restoration after fully digital approach. From here to here. The shape is not very aesthetics, but as I told you before, we need to control the function and to reduce. Look here, lateral guidance on the right, on the left, and the anterior guidance are perfect. So I want to move in the last maybe 10 minutes on some cases with implant and digital anterior and complex cases. This is Stefano. He needed two lateral upper lateral incisor because he have an agenesis, but he need orthodontic treatment. So after orthodontic treatment, we plan space opening in the lateral position. The case started 6 years ago. And finally, when the orthodontic treatment was almost finished, we can start with impression. Intraoral scanner is also very nice for interdisciplinary treatments. For example, patient with the brackets, we can take the impression without any kind of problems for the material inside the brackets. Look at the impression, CBCT scan, as I told you before, the patient must be the mouth opened, intraoral scanner, CBCT scan, and we merge in a software. However, we need a Vox-up because these are just two teeth for aesthetic reasons, but it's very important in the anterior area to have a perfect Vox-up because we need the vertical position of the implants. We need to plan the vertical position. So we need the cervical margin of the teeth that must be very precise because the dipping of the implants is very important in aesthetic area. So Smile Creator, picture as I showed you before, intraoral scanner as I showed you before, but also DICOM because we need to plan the implant in this case. Segmentation of the teeth, as I told you before, proportion, measure, and then virtual Vox-up. It's very important to have the perfect cervical area of the teeth to be rehabilitated because I will plan my implant position according to the cervical area of my teeth, but also according to the inclination and position of my teeth. However, the planning will be the topic of our next webinar. So this case will be continued in the next webinar. Another case, Beatrice, she lost 4 central lateral incisor when she was 10 years old for a car accident. She had a big bone resorption, vertical and horizontal, but she wear this prosthesis. Is not best prosthesis, but allow her to have a lip support. So the challenge of this case is not only the bone reconstruction, aesthetics of the teeth, aesthetic of the soft tissues, but also support for the lip. So I scanned the temporary prosthesis in order to have a reference point for my surgeries. This names computer-guided bone regeneration. Computer-guided bone regeneration is the protocol to establish in advance the amount of bone graft for aesthetic reasons. And I published a lot of manuscript with my friend Silvio Meloni. Here you can see the computer-guided bone regeneration philosophy, calculated in advance the bone graft according to the support of the lip, and this is the first step. And I use the temporary removable prosthesis in order to have a starting point for my surgery. Here you can see also the planning of the implants, but as you can see, it's not possible to place the implant in one stage together with the bone reconstruction. Here, some publication of the computer-guided bone regeneration philosophy, the first 8 years ago. Looking at the SMILE pre-visualization, as I told you before, is possible to create some customized library. As I told you before, the first step is picture, intraoral scanner, merging, looking at the proportion, and then the library of the teeth. But in some cases, the standard library are not so good. In this case, I copy the library of the mother of my patients in order to create a customized library, because in their family, we have the possibility to have the same shape between the mother and the daughter. I have not a reference point, so I copy the shape of the mother in order to have a customized library. And this is the plan: implants, amount of bone graft, SMILE creator that allow CBCT scan DICOM file, works up from the SMILE creator STL file. Anatomy is this one. This is the anatomy, the soft tissues. This is another STL file. Amount of graft, another STL file. All of these files are merged in the same software in order to plan the surgery. However, as for the previous case, this is just a spoiler of the finalization. The mother and the daughter after guided bone regeneration and implants. I will show this case in the next webinar, looking at the step-by-step protocol that we want to share with this webinar. The last case, maybe 6-7 minutes, is Diana, another mother of my assistant. Diana started with a very dramatic situation, very quickly, intraoral views, frontal, a lot of oplet teeth in the maxilla, one solitary tooth in the mandible. Extraoral examination was dramatic because it was impossible to make her smiling. This is the maximum. This is the radiograph, but I will show you also the full mouth radiograph. So, moving to the fully digital approach. This was my first complex maxilla and mandible complete arch restoration on implant, performed fully digital, maybe 6-7 years ago. Intraoral scan, vertical dimension of occlusion. I use the digital movements to remain in the fully digital approach, but also because I need a reference plane for the maxillary arch. I need a mandibular movement for the patients because I have not any kind of reference. I'm just the condyle of the ATM, TMG. So after some urgent treatment, I start my workup. But as I told you before, I have not reference point. So I can create my workup. Of course, starting from the impression, picture, 2 points in order to merge the data, 2 picture with or without a retraction, as I showed you before. And also superimposition of the anatomy of both, because in this case I need to rehabilitate upper and lower jaw. DICOM file, because I need to plan my implants, and also facial scan. So I have perfectly my virtual patients. as you can see here. But as I told you before, I have not a reference point, but Janina, her daughter, works in my clinic. So Smile Donator, as I told you before, impression of the Janina to create a customized library. So when I planned the virtual workshop of her mother, I just open customized library from her daughter. This is the case, the smiling, the new library after segmentation, planning longer teeth, gathered surgery. I can plan everything, the length of the teeth, because I need to reestablish everything. But of course, it's very difficult to trust in a digital workflow, particularly 6 years ago. But starting from the virtual workshop, as I told you before, from the patient with 5 crowns in the anterior, I can print a prototype. Here you can see the upper and the lower prototype, so I can test in the patient mount, I can test the aesthetics, I can test the function in order to make some modification or just to control that everything was good. Once again, the movements with the new prototype. So I have the movements at the beginning and the movements with the prototype, and I can check and adjust again. This is the anterior guidance before you see the lateral. Again, the protrusion. So here you can see that I can simulate all the movements using the acquisition of the DICOM data, acquisition of the intraoral scanner, just with a Smile Creator to create a virtual workshop and print the model. In this case, I also use the digital mandibular movements, but you can test in the patient mount with the prototype. Here you see also the CBCT scan, all aligned in just one file, because starting from this temporary restoration, virtual temporary restoration, I need to plan my implants. So I can plan the implants looking at the aesthetic and the function in a very complex cases. Why complex? Because I lost all the reference point. I just want to spend 1 minute in the last slide, because planning the implants without taking into consideration aesthetic, phonetic, and function is very dangerous, because the implants are fixed. And then we can plan some compromise with the prosthesis, but I don't like the shortcuts. I don't like compromise. So I want to plan my implants in the perfect prosthetically driven position. And the perfect prosthetically driven position comes from function, aesthetic, and phonetic. And in order to plan this one, or I need to use a removable denture, some bites to test, but as I showed you before, we also can use digital technologies. So this is another spoiler with the Janina's mom, with the temporary restoration, and Janina after implant placement. However, as for the previous cases, in the next webinar, I will show the next steps, because with Austin Middle East, that I really thanks once again, we plan to have 5 webinars with step-by-step from digitalization of our patient to finalization of our cases. I really want to thank all of my staff. I really want to thank once again Austin. As I told you before, today we spoke about scan, digitalization of the patients, IO scan, CBCT scan, and virtual workshop using Smile Creator. Next webinar, in about 1 month, we will speak about planning, using the collected data to plan our implants in single, partial, or completely arch restoration. After summer, we have the execution. We will see a lot of clinical cases, surgical procedure. I will share with you some tips. And then in the last two webinars, finalization from single to complete a large restoration. Steve, I have finished my presentation. I don't know if we have some question.
Yes, Professor. Thank you for this.
Also, most in time. Okay, perfect. 1 hour.
Yes, perfect time.
Okay.
Okay, so we have a few questions. The first question is asking Dr. Rawan. She's asking about what program you are using.
Okay, for intraoral scanner, I use the Medit. The Medit is a very nice software for scanning, but also a lot of apps for prosthesis, marginal line, orthodontics, aesthetics, etc. For planning, in the past, I use a lot Real Guide from 3DM. Now I'm moving to Exoplan. I use both in this time, so we will see both software. And for the Smile Creator, I use Exocad. That is a tools of the Exocad. I have in my clinic the chairside module dedicated for dentists, but Exocad, a lot of dental lab Exocad, and there are inside the Exocad the module of the Smile Creator. However, there are also several apps in the iPhone or not that allow for pre-visualization of the smile. I love this software because allow me to work in bidimensional view from a patient point of view, but also with a 3D model that allow me to print temporary prototype, etc. Another question?
Yes, we have a question from Dr. Kwazurov. I wish I pronounced well. So how did you register the centric relation? Is it according to a clinical manipulation or a pre-recorded digital data?
Wow, thanks for the question, because I teach prosthesis in my university in Sassari, and this is a very important topic. Basically, we have two different schools. I follow the mechanical school of Peter Dawson. I record centric relaxation manually. However, I change a little bit the concept of centric relaxation, because centric relaxation was Peter Dawson gave an anatomical definition. I don't like the anatomical definition because we don't see the TMJ, etc. But from a mechanical point of view, I want to record the mandibular position and the maxillary position in the pure rotation movement up to the first contact if we have referent teeth. If we don't have referent teeth, I use phonetic test, FS 51, 52, 61, 62, in order to establish the position of the upper incisor, position and inclination, with the F sound and with the S sound, the position and inclination of the lower incisor. I record them manually, even if I use digital instrument, because with the digital instrument, I need to support my patients, and usually I register the centric relaxation with a manipulation, be manual or single manual. But as I told you before, the centric relaxation is the pure position of the mandible against the maxilla in the pure rotation movement immediately before the first contact. That if I don't have teeth, recorded with the phonetic. When I move the patient in this position with bimanual or single manual movement, I recorded in the software. I also recorded maximal intercuspidation. I also recorded rest position. I use this kind of occlusion. Maximal intercuspidation if I don't need to change the occlusal scheme and the vertical dimension. Centric relaxation if I need to change occlusal scheme or or vertical dimension. Rest position just to have some more information in case I need to improve vertical dimension. I think the answer should be clear. Another question?
Yes, Professor, the answer is clear. Thank you for your answer. We have a question from Dr. Ali Al-Bahraini. If a patient is missing all the upper 6 teeth and the lower anterior 6 teeth also, how can you make functional design if no condyle information is available?
Okay, the question from my point of view is not very clear. I try to interpret it. If the patient is missing all 6 upper and lower, I don't know why the condylar information should not be available. Maybe if I can understand if the doctor have not an instrument to record there, because if the patient lost just the anterior, first of all, we have stability on the posterior, so I can record occlusions. The same with the phonetics, because I really enjoy the removable prosthesis because it's the starting point, give me a lot of training to rehabilitate the patients. In the removable prosthesis, the first step is to define the 6 upper teeth. And of course, we need to consider it, as I told you before, the phonetics, but also the aesthetics, unfortunately. So we need to find a compromise. So just to answer the question, I will, in this case, upper impression, lower impression, and put maybe maximal intercuspidation, but with face bow and medium value articulator. With the face bow, because I need to set the plane. Maybe the plane could be a little bit tilted. So I want to fix a reference point, the maxillary. I want to put in the articulator the maxillary position according to a reference plane. In case of removable prosthesis, I use the camper plane. In case of fixed prosthesis, I use the Frankfurt plane. So face bow is mandatory to realize the 6 upper and or lower incisor. After the model in the dental articulator, I need to test with the phonetics, because with the F sound, I can define the vertical length of the teeth, the upper teeth, and the inclination. With the S, the inclination and length of the inferior. In case I need to rehabilitate both upper and lower, I can also use the cingulum of the anterior teeth, because if I have too much longer teeth, I can improve the cingulum and to reduce, for example, the length of the lower incisor. However, after these steps, impression, face bow, articulator, medium value, phonetic test, I need to test with temporary. Temporary could be removable or not. However, in case of implants, I want to do everything before, because to make the implants in a good position for function and aesthetics, I need to know the perfect position of the teeth. And as I told you before, in the anterior teeth, inclination, position, and vertical, not only mesiodistal and bucco-palatal position, inclination and vertical position as very important. I hope to give you all the information, but in general, impression, face bow, dental articulator, phonetics, and test. Test with a prototype, as you saw before, with a prototype in order to test aesthetics, because it's very important from a patient point of view, and function. With the prototype, I test again protrusion and lateral guidance. Other question?
Yes, Professor. Thank you for your answers. We have just a last question. What mean prototype? Is it a module?
Prototype is something printed by using an STL file and a printing machine. In case of, I share again my screen. For example, I name this prototype. Prototype is a physical object printed by an STL file. Also, a model like in this case is a prototype model because it's printed by an STL file designed in a software. This is a prototype model, this is a prototype temporary, and this is a prototype aesthetic train. I'm sorry for misunderstanding, but thanks for the question that allowed to explain. Prototype is any physical object printed by an STL file. Also, a surgical template is a prototype template. Okay.
Okay, thank you, Professor. I think this all questions we have so far. So
One
thank you very much.
One question is for you. I'm asking about certificate, but this is for you.
Yes, yeah.
Maybe you can answer in private.
Yeah. Okay, so we thank you very much for your amazing lecture. It was, I'm sure everyone learned a lot today. We have got a lot done today. And thank you all for your time participating in the live webinar.
Yes, me too. And I hope also it's not easy to share a lot of years of experience in 1 hour, but my intent was to give some information, innovation, but also curiosity to follow the next webinar. So we can go deeper in some arguments. I hope to do this one. And thanks to Steven, thanks to all the OSTEM Middle East and OSTEM worldwide, and see you soon.
Yeah, thank you, Professor. So we'll see you soon again.
Thank you too, and thanks to all the attendants.
Next. Yeah. We are waiting for your next lecture next month, and 25th of August.
Yes,
everyone can save the date.
Planning. Okay.
Yeah.
Thank you, Steven.
Okay. Thank you again, everyone. Thank you, Professor.